All right, let's walk through a classic PLAB2 scenario, gout. By the end of this, you're going to have a really clear framework to confidently handle this station.
Now, this is a high-yield scenario, which means it comes up a lot. Getting the structure right isn't just about ticking boxes. It's about showing a safe and systematic approach. That's exactly what the examiners were looking for.
So, your consultation starts the second the patient tells you their problem, pain in their big toe. Your first job is to explore this pain thoroughly before you even think about diagnoses. Let's start with how to nail that initial history. Look, you're going to want to dedicate the first 3 to 4 minutes just to taking a detailed history. A systematic approach will stop you from missing crucial details, and honestly, it helps you start building your differential diagnoses right from the get-go. Your absolute best friend for this is the Socrates framework. It gives you a reliable structure so you cover every single aspect of the pain. But don't just rattle through the mnemonic. You have to actively listen to the answers. They're what will guide your clinical reasoning. So what's really cool is how you can weave Socrates into a natural conversation. You start broad. Hello, how can I help you today? Then you narrow in. When the patient says, I've got pain in my big toe, you just follow up. When did it start? That's your onset. Could you please describe the pain for me? That's character. See? It flows right from what the patient tells you. In this classic case, the patient's going to describe a sudden onset of sharp pain in one joint, with redness and swelling. Notice how these findings, sudden, sharp, a 7 out of 10, red, and swollen, are already pointing you strongly towards an inflammatory arthritis, like gout. With those initial findings, your mind should immediately jump to the most serious differential. What is the one diagnosis you absolutely cannot afford to miss? That's right, septic arthritis. So the crucial point here is telling these two apart. Septic arthritis is a medical emergency. The key things you have to ask about are systemic symptoms, specifically fever, and any history of recent trauma to that joint. These two questions are mandatory. A simple, direct, any fever, followed by any trauma to the joints, will give you the answers you need. In this scenario, the patient's going to say no to both, which makes septic arthritis way less likely and really strengthens your suspicion of gout. Okay, so once you've explored the pain and ruled out the big red flags, it's time to dig into the patient's background. Their medical and social history are going to give you the clues that can help lock in your diagnosis. Now, this slide highlights a critical connection. The patient has hypertension and is taking a thiazide diuretic. When you ask, they'll confirm the pain started right after they began this medication. So why is this a classic trigger? Well, thiazides can reduce how well the kidneys get rid of uric acid. This leads to higher levels in the blood, which can then crystallize in the joints and cause that intense pain. For the social history, you can use a simple framework like DSA to keep it structured. Diet, exercise, smoking, and alcohol. All of these are pretty significant lifestyle factors for gout. And here, the history reveals significant alcohol intake, 3 cups of wine daily for 15 years, and a lack of exercise. Both are major risk factors. You now have a really compelling case for a diagnosis of gout, backed up by the pain history, the medication history, and the social history. Okay, now that you've gathered all your information, you'll do a focused examination and then explain your findings to the patient. Your communication here is being assessed just as much as your clinical knowledge, so pay attention. So here's how you can explain your findings. Start by summarizing what the patient told you. It shows you were actually listening. Then present your suspected diagnosis in simple, clear language. Instead of medical jargon, you can say something just like the quote on the screen. It's clear, it's empathetic, and it's easy to understand. Now for the final part of the station, management. This needs to be comprehensive. You have to cover investigations, treatment for the acute attack, long-term prevention, and of course, safety netting. First up, investigations. You'll arrange blood tests, including uric acid levels, renal function tests or RFTs, and urea and electrolytes, your UNEs. It's so important to check kidney function because it directly affects how uric acid gets cleared. You also want to check fasting glucose and lipids, since gout is often linked to metabolic syndrome. You should also mention referring to a rheumatologist and the possibility of joint fluid aspiration, which is the gold standard for a definitive diagnosis. You know, structuring a management plan under exam pressure is a key skill. You can practice this exact case and get objective feedback on mymighty8.com. Next, you need to get the patient clear, practical instructions for managing this acute attack. This advice is all about empowering them. Tell them what to do.
Take their prescribed NSE or colchicine, rest and elevate the leg, and use a cool pack. These are simple actions that are going to make a big difference.
Then, you've got to discuss long-term prevention through lifestyle changes. Frame these as positive actions. Talk about getting to a healthy weight, having a balanced diet, and bringing in regular, low-impact exercise. This is about their long-term health, not just this one attack. It's equally important to be super specific about what to avoid. Give clear, no-nonsense advice. Do not eat high-purine foods like offal and certain types of seafood. Do not have a lot of sugary drinks. And give them specific guidance on alcohol limits. Clarity here is what prevents future attacks.
And finally, you have to close the consultation professionally. This involves two critical parts: safety netting and arranging a clear follow-up plan. Your safety netting advice is simple but absolutely vital. If you do not feel better after starting the treatment, or if you feel worse, come back immediately. Then you give a clear time frame for follow-up, usually in 2 to 3 days, just to check on their progress.
So, the common thread here, from a thorough history all the way to a safe management plan, is a clear, logical structure. This framework isn't just about passing an exam, it's about being a safe doctor. The real question is, can you apply this structure confidently under pressure when it really counts? The only way to know is to put it into practice. You can work through this exact case now at mymedia.com.